a long case and you get 70%, 60% marks in the long case, but in the specimen you can get the 100% marks. So it is important. So before going into details, let us see what we should do. First of all, whenever you are given a specimen, you should be slow. Don't jump on to identifying the specimen. First see the specimen, observe the specimen, identify the anatomical site from where the specimen has been obtained. Try to locate the pathology that is present. And recollect what surgery has been done. After you have identified the anatomical site, seen what pathology has been over there in the specimen, and the surgery that has been done, after you have done all three things, you should take up the specimen for viva voce. Taking up the specimen, I mean, you should place the specimen in proper anatomical position. Place the specimen, don't pick it on your hand, place the specimen on the table in proper anatomical position. Now you start answering. So what are the points you should say? First, number one is, this is a formalin fixed specimen. Second, it has been weight mounted. Third, you may or may not say this point, this is an ante-mortem, because we are not anatomists, we are surgeons. Whatever specimen we get, those are not obtained after the death of the patient, but those are obtained following any surgical excision. So these specimens are most commonly ante-mortem specimens. In anatomy lab, you had all post-mortem specimens. These are all ante-mortem specimens. And 4 is off. So this is a formalin fixed, weight mounted, ante-mortem specimen of dash showing dash. Now the fixed question from the examiner will be 2. One is, why do you say this is a specimen of dash, that you have already said, why? Number 2 is, what surgery was done to obtain the specimen? These are the 2 fixed questions that you will have to answer. That will fetch you 50% of the marks. The rest is all theory. The rest has got nothing to do with the specimen. Why and how was the specimen harvested? That means the surgery. So let us start with the specimen of, till this is made, let us continue the discussion. Let us not waste any more time. We all have to go home. So this is a formalin fixed, weight mounted, ante-mortem specimen of total laryngectomy with partial pharyngectomy and right-sided hemithyroidectomy. This is the entire thing. This is not a specimen of only total laryngectomy. This is a specimen of total laryngectomy, partial pharyngectomy with right-sided hemithyroidectomy, showing a ulceroproliferative growth involving the right hemilarynx. Showing an ulceroproliferative growth involving the right hemilarynx. So what surgery was done? You have already said the surgery is total laryngectomy, partial pharyngectomy with ipsilateral hemithyroidectomy. Now you might be asked, please place the specimen in proper anatomical position. You should place it as it was in a normal subject. And now you might be asked about the steps, you might be asked about the staging of the disease, what other treatment modalities are available, what could you have done. Now in total laryngectomy, to simplify it, write down 4 steps of total laryngectomy, 4 steps so that you remember. Step 1, I am not going into positioning of the patient, anesthesia, preoperative preparation, all those things. These are the 4 basic steps so that you don't forget during the exam. 4 basic steps of total laryngectomy. Step 1 is skeletonization. Step 1 is skeletonization. Step 2 is mobilization. Step 3 is resection. And step 4 is reconstruction. Skeletonization means, you all know, first you elevate the flap, cut away the straps, identify the vascular supply, clip those vascular supply of the larynx. This is skeletonization. Mobilization means you cut the straps and mobilize the larynx from the infrahyoid, suprahyoid and infrahyoid structures. Number 4, resection is circumscribing round the growth. Circumscribing round the growth and formation of a neostoma or a permanent tracheostoma. And reconstruction is formation of a neopharynx with or without grafting. So these are the 4 basic steps so that you don't forget during the exam. Our next specimen is, this is a specimen of, this is a formalin fixed weight mounted antemortem specimen of total maxillectomy of the right side. You should identify the side. Most commonly the specimens that are given to you are not bilateral maxillectomies. Most commonly it is a unilateral or one-sided maxillectomy. So this is a specimen of right-sided total maxillectomy. This probably is not. This probably is a partial maxillectomy because the orbital plate or the roof of the maxilla is absent. But for all common purposes in the exam, you will be given a specimen of total maxillectomy most commonly. So how do you identify these as maxilla? Because of the presence of anatomical structures. What are the structures that helps you identify a maxilla? What? So there are some surfaces and there are some processes. What are the surfaces? Pyramidal bone, anterolateral surface, posterolateral surface, orbital surface, nasal surface, and you get some very important processes. Alveolar process, you can identify the teeth, the frontonasal process, very good, and the zygomatic process. So these are the very important processes. So this is a specimen of what? Right-sided total maxillectomy. ঠিক है? এর বেশি দরকার নেই, পড়ে নিবি বই থেকে। আর কি কি স্পেসিমেন জানতে হবে? You should know specimen of total thyroidectomy. Why you say it is a total thyroid? You should have to say that. Why do you say it total thyroid? আর জানবি সব স্পেসিমেনগুলোতে সবাই প্রথমেই আনসার দেবে, দ্য ইটিওলজি অফ দ্য ডিজিজ ওয়াজ আ ক্যান্সার। জামাই ঠকানো কোশ্চেন হচ্ছে, কোন বিনাইন কন্ডিশনে তুমি এটা করতে পারো? ওটা পরীক্ষার সময় মাথায় ক্লিক করে না, বিকজ ইউ আর ওয়ার্কিং ইন আ সাবকর্টিক্যাল লেভেল। কিপ দ্যাট ইন মাইন্ড, what benign condition this kind of radical surgeries can be done. ঠিক है? আর একটা সাইনোনেজাল মাস অনেক জায়গায় থাকে, অ্যান্ট্রোকোয়ানাল পলিপ। Don't say it to be an antroconal polyp. It seems odd with EPOS 2020 and 2022 all guidelines in our hand. It should be a case of sinonasal polyposis in a case of chronic rhinosinusitis. Now I will hand over the microphone to Dr. Devanshu. He will say a few words.
Good afternoon, everybody. Congratulations, because we are going to sit up your final exam. Hope you all have a very good exam at the end. So all said and done, more or less 90% covered by Shoykot, Dr. Shoykot. One thing I want to reiterate, whenever you get a specimen, suppose he has taken up, is it a larynx, it is a thyroid. First question may be asked, why it is larynx? Suppose you have said, what is the specimen? You have identified by seeing it meticulously, okay? He has said to see it very slowly at the first point. So you have identified the organ. So it is human larynx. Now, can anybody tell me why it is larynx? Suppose examiner asks the next question, why it is larynx? Why it is not thyroid? Why not the larynx specimen is a thyroid specimen? What should be your answer? Come up please, because this lecture should not be a didactic one. You should come up with something. You have to say something. Now, why it is larynx? So ideal answer should be larynx. It is a larynx, sir, because larynx is a structure formed by cartilages and ligaments internally lined by membrane and moved by muscles. This should be the ideal answer, because I can see all of this inside the specimen. So this is the human larynx, because you can see here some cartilages are there, you can see there. If you can see meticulously, you can see the cartilages, thyroid cartilages you can see. If you come up, please zoom in the picture. You can see the thyroid cartilage split open here, this two ala of the thyroid cartilage. Can you see that? If we rotate the specimen, no, this side we cannot see that. Okay. Also, there is another specimen you see. Please focus here. Can you see the epiglottis? Can you see the superior horn and inferior horn of the thyroid cartilage? Isn't it? So, this structure you have to identify first. To identify anatomically that it is larynx. Okay, then you have to see what pathology is arising out of that anatomical structure. If you see that, the next thing, can you zoom in here? You can see a growth, you see? You can see the growth clearly. Can you see the growth? Here is the growth, you see, this side. So it is the ventricle of the larynx. One growth is crossing the ventricle. So mostly in our day-to-day scenario, in which case of growth of the larynx, we do the total laryngectomy. If you have in your mind that it is a specimen of total laryngectomy, okay, or with partial pharyngectomy or whatever, what he has said, then in which growth in our day-to-day practice we do this operation, surgery? Transglottic carcinoma of the larynx, isn't it? Then what is transglottic? Any growth of the larynx that transgresses the ventricle of the larynx from below upwards or superior to inferior, isn't it? Crossing the ventricle of the larynx. So one indication that from there coming the indication of the total laryngectomy. One is the transglottic carcinoma of the larynx, and by definition transglottic goes to which stage of the T stage of the laryngeal carcinoma? TNM? T3. Okay. Transglottic always means T3. And what is the next common indication? Leave it the transglottic. What is the next common indication of the total laryngectomy? What may be? Question comes this way. Then stage wise, one is, you see, compromised structure of the larynx. Somebody is telling, na, compromised structure of the larynx. There comes the staging where the total laryngectomy is done. Number one is T3. Number two is T4A, where the cartilage is involved, isn't it? Third is where the laryngeal growth involving the subglottis. That is also another indication of total laryngectomy. Okay. So, this is the indication of total laryngectomy structure wise, where the laryngeal structure is compromised by the growth. Then come to the functional compromise of the larynx. There are some indication also for the total laryngectomy. What are those? This is otherwise known as dysfunctional larynx. What are those? Suppose there is a history of aspiration. In a laryngeal cancer, patient is giving recurrent history of aspiration as well as respiratory distress, for what tracheostomy has been done. Okay, that means laryngeal inlet has been covered by the growth. No airway can go in and up. Okay, so this is the second indication of the dysfunctional larynx, the cause from that point. Any other indication you know? Radio-resistant tumors, or suppose there is a, that is after CTRT means CTRT is given usually stage 3 laryngeal carcinoma. Okay, that is as a part of organ preservation protocol. Stage 3 is ideally treated by organ preservation protocol. We want to save the larynx. That larynx has to be functional one. Not with that aspiration, not with the respiratory distress. Okay. So, as a part of the organ preservation protocol has been failed due to any reason. That may be another indication. Or patient cannot tolerate the chemotherapy due to medical reason. Suppose organ preservation protocol with CTRT has been advised, but patient cannot tolerate that CT chemotherapy due to renal compromise or any other reason. In that case, you have to put the patient for the surgical site, surgical arm. In that case, total laryngectomy can be undertaken. Okay, or some radio-resistant tumor, recurrent tumor, there is a term known as completion laryngectomy. Do you know that? What is that? Completion laryngectomy, just like completion thyroidectomy. What is that? That is failure of the laryngeal preservation surgeries, partial laryngectomy, that disease has recurred again. Okay, in that case you have to undertake the rest of the whole larynx has to be taken out, known as completion laryngectomy. Can you name any other tumor where laryngectomy is undertaken apart from all those? Total larynx is done, total laryngectomy is done. Any other tumor, any other pathology of the tumor? Huh? No, their treatment protocol is different. Hypopharies come in the pyriform sinus growth and all these areas, subsides. Their treatment is mainly radiotherapy or chemoradiation, concurrent chemoradiation. Very good. Thyroid cancer invading larynx. Suppose there is a papillary carcinoma of thyroid invading laryngeal inlet and has gone to the endolarynx. In that case, you have to do, along with total thyroidectomy, you have to undertake total laryngectomy also. Or any other peculiar tumor, suppose any tumor arising from the cartilaginous framework of the larynx, any soft tissue sarcoma, chondrosarcoma, very ferocious tumor. Okay, in that case, you have to undertake total laryngectomy. Okay, so per se, it is not a mucosal growth, but cartilaginous framework growth or any thyroid cancer, you have to undertake this one. More or less, these questions will be asked, and you know how to prepare a patient for the total laryngectomy. This may be asked. That we have not much time of that. Okay, and according to another specimen, this is the specimen of total maxilla. Suppose total maxilla. Basically, orbital plate has not been in the specimen, so it cannot be told as a specimen of total maxillectomy. Okay. So now coming to the part, there are several classifications of the maxillectomy. What are those types of maxillectomy? You know. Again, this identification of this already told by Shoikat. Why it is maxilla? There are processes: anterolateral surface, posterior medial surfaces, inferior surfaces covered by the teeth. You can all see that here. Okay, so it is maxilla, no doubt of that. Okay, now tell me, in any sinonasal malignant cases, we undertake this maxillectomy surgery. Maxillectomy, several types are there, starting from the total maxillectomy, then subtotal maxillectomy, then partial maxillectomy. Now, you have to know two classifications, very important. One is on-grain classification, one is Lederman classification. You know that? Because you see, maxilla has been divided into suprastructure, mesostructure, infrastructure. Okay, because prognosis different on all these regions. Prognosis very bad because if the growth goes high up in the maxilla, close to the orbit, prognosis becomes very bad. If it remains lower down, prognosis is good comparatively. So this sort of maxillectomy where if you divide into 9 quadrant, the lower horizontal below, any tumor situated below the lower horizontal quadrant is known as infrastructural maxillectomy. Anything above is known as grossly suprastructural maxillectomy. Okay. So, on total maxillectomy, all the cards you have to know. Immediately after you identify the specimen, examiner will jump on you to ask the cards of the total maxillectomy. Okay, it is a very common question. 4 cards. Okay, and also partial maxillectomy cards are separate. That you have to know. What are the cards? Mucosal cards. Mucosal cards, incisions as well as bony cards. Okay, that's all. That other of the theory, you have to know that. Any question? Point wise mone rakhte. What is the first card? Palatal. Palatal card.
Number 1 is malar cut. Number 2 is palatal cut. Number 3 is frontoethmoidal cut. Number 4 is orbital cut. And number 5 is at the region of the pterygoid.
Pterygoid. Okay. These are the cuts.
These are the 5 basic cuts. Here onek variation ache. As you are doing post graduation, you will have to know all the variation and all the things which will be expected of you. But these are the 5 basic cuts that you should always remember and you should not falter. There are variations in various books, and as Dada has said, the classification of maxillectomy. Actually, classification of maxillectomy you should also learn by heart. Memorial Sloan Kettering Cancer Center classification. There are 6 classifications of maxillectomy. Those are very brief as well as structured classification. Yes. You can go through that. That will be helpful. And the last thing that I will say to you, see, passing the exam is not the motto of anything. Definitely you all will pass the MS exam, and that too in flying colors. What we all expect is we become good ENT surgeons, we love the subjects, and we come back and meet again and again. Thank you.